Betsy Mendropoulos, Nate Vanderpool, and we have been working in telemedicine during the last few years, and we have implemented telemedicine to our practices. But now with the coronavirus pandemic, I think it became relevant, and it's important for all of us to understand what it means, how we can do it, and a couple of tips that we can give you guys in terms of what is telemedicine and how practically you can actually do your e-visits. So there are different tools that we have in the market now, but we're gonna concentrate in what we have at HHS, which is OTN and OTN Invite. So I'm going to start with the presentation. I'm going to thank Dr. Crowder for his support. He has been helping us in the last few years in creating a telemedicine interest group at McMaster, and also working in partnership with HHS. Nate is the leader in virtual care at HHS, and he is the liaison between the university and the corporation. So why we're going to talk about why virtual care, the challenges that we have, that we're facing now in our practices, the platforms that we use, the payment types that we have with OHIP, the care pathways that we have implemented at HHS that we should all follow. That's going to be Nate, who is going to help us with that part. And also how to set up and conducting an e-visit in our practices, because it's required a lot of prep before going live. And then at the end, what we're going to do is a quick demo using this share tool. I can share one of my screens and go through how you sign in for OTN, and two, how you do a video visit, basically. All right, so March 17, as you probably, well, we all are aware, so it was declared a state of emergency in Ontario, and that led to healthcare providers to face some challenges in terms of how we're going to provide medicine in the during these times. And one of the things that we have to avoid is bring people to hospitals, especially us that we have practices in teaching hospitals. So the idea of using telemedicine became more relevant, and as a group, we decided to share our experience and provide you with some advice in terms of how you can use it. The challenges that we have now are basically related with, hospital-based specialty clinics, right? So what we're doing in our clinics, how we're going to follow patients, how we're going to see new patients. Also, hospital-based rapid assessment clinics, they are also struggling on how to bring patients to hospital. What we're going to do with the new referrals, the follow-ups. Now, how we can provide advice to pharmacists, to caregivers in a protective environment, as well as giving critical care advice, and also communicate with community-based organizations, because CCAC, they also have access to OTN and some of these tools that can be helpful with our patients now that we have to keep them away from hospital. We need to decrease exposure, and particularly our patients are sick patients, so we don't want to get them to get the coronavirus. So we have two types of platforms, okay? We have direct patient contact via telephone that we probably are familiar in the past with. We call the patient and we give the advice. But we have now what we call the e-visit, the home video visit, which is a platform that has been developed in the last few years in order to, using protected environment, communicate with the patients at home, basically. The important thing is that it needs to be documented on EMR, and this is something that we're going to discuss during the process of how to set up e-consult. Require patient consent, and according to the CMPA, right? So if it's done in the proper way, you have full protection in terms of liability. Now I'm going to pass to Ted.
Thank you, Juan. So essentially, there are a number of platforms that can be used for conducting telemedicine, and sort of the backdrop of the OTN program that sort of catalyzed basically sort of direct to patient or personal video conferencing was the e-visit program, which was initially piloted by a small group of 500 physicians in Ontario in 2018, and certainly has been extended to all physicians this past year. The platform, the OTN platform, is the officially HHS approved platform, and is certainly the platform that Juan and myself, as well as Nate, have the greatest familiarity with. It is important to recognize that there are a variety of different ways to communicate with patients in the telemedicine ecosystem. So there are a variety of different proprietary platforms and products by a variety of different systems, both standalone and EMR-based systems, some of which are mentioned here in this slide. Many of them, if not all of them, have adherence to regulatory standards, particularly around privacy and security, such as PHIPAA compliance, that allow them to be utilized in the context of transmission of sensitive patient information. And so it's important to recognize that there are a variety of different platforms that can be used, but the HHS approved platform at the present time is the OTN e-visit program. Now we'll go to the next slide. So when we think of telemedicine and certainly communicating with patients, I've had a variety of different colleagues inquire about it in the context of a variety of other applications. And certainly many of us, if not all of us, are familiar with some of these listed on this slide, such as Skype or using FaceTime, Zoom, as well as Google Hangouts, in addition to a variety of different platforms that offer a variety of interesting functionality and potential. It's important to understand, of course, that these are not PHIPAA compliant and certainly not appropriate for standard communication in a telemedicine context of sensitive patient information. That being said, of course, providing patients with consent for exchange of information by a variety of different mechanisms, including some of these mechanisms and the telephone, does require specific documentation and elaboration of the consenting process. So it's, again, important to understand that one can apply some of these platforms so long as the patient is aware that the privacy and security of these platforms cannot be confirmed or at least validated in context of information exchange. Move on to the next slide. So as far as payment, really this is sort of an area that has recently changed dramatically in the context of the COVID-19 outbreak. And certainly the sort of social distancing movement and providing remote care has taken a strong place in the face of provision of medical care for our patients. And so the Ontario Ministry of Health recently came up with a variety of different K codes in application for our patients for remote care models. Now, I won't go into the details of these codes. There are some complexities that are nuances related to your particular practice, but the essential message here is that K codes can actually be used for telemedicine and or telephone encounters. Now, there are specific B codes for those already registered with the Ontario Ministry of Health for provision of telemedicine services that are traditionally used to designate a telemedicine encounter and application of the typical Ministry of Health codes that were historically used. But suffice it to say that for simplicity's sake, for those using either telephone or applying for telemedicine privileges in the current context, K codes would be the standard approach to payment. These codes are effective as of March 14th, but processing of these claims has been suggested to delay for about a month because of software upgrades to the billing systems at the Ministry of Health. We'll go on to the next slide. And I'll pass the discussion of the integration of e-visits and the administrative aspects to my colleague, Nate.
Hi, everyone, and thanks for having me. It's considering the situation, it's still a neat time to get together and to talk a little bit about virtual care and how it can be used, particularly in the context of wanting to maintain the ability to provide care to all of our patients, obviously. So with respect to what Ted had said earlier, we do, we have been using OTN at Hamilton Health Sciences, and I know, given this is a Department of Medicine call, and there's probably others from the Faculty Health Sciences as well. There probably are some of you that don't specifically work at Hamilton Health Sciences, but so far, we've primarily been using OTN, but just wanted to highlight to Ted's point that, given the circumstances and given the work that's been done at the OMA and by Ontario MD, that where required or where it fits in better, we are happy to support and have conversation about other platforms as well. Particularly as it relates to your individual clinics and outpatient practices. Ultimately, what we're really focused on doing is removing barriers to the extent that we can to enable you to be able to deliver the care that patients still expect and deserve. So, and in addition to that, just wanted to say thanks to everybody for your commitment at this time. As it relates to integrating e-visits into care pathways and processes, we've tried to keep this fairly high level so that it can be applicable to a bunch of different applications and even across things like phone or video visits, for example. So not just exclusive to video visits and OTN. But certainly one of the first steps, obviously up on the slide there, is around access, making sure that that you have the access you need and are able to figure out how to gain that access, and then also presumably administrative staff as well who are going to be helping out in booking. And that brings me to the next point on the slide as well. Certainly at Hamilton Health Sciences and most likely at other institutions as well, there's still a keen interest in making sure that we capture these type of visits, whether it be phone calls or e-visits, in our booking systems as well, because ultimately those things become a part of the patient record, which is important to have the documentation that the visit occurred, and then also what your advice was, so on and so forth, and that becomes again a part of the legal patient chart, and is accessible in the future. So really important to make sure that that happens. Then in terms of material and support, want to be thinking about what kind of things your patients might need, either for their education in the system and how they should behave and participate in this kind of a setting, and how they might be able to access it as well, and also thinking about supports if there are technical difficulties. So making sure that you're set up and have the resources that you need to be supported if there's technical difficulties on your end or on the patient's. Another key thing that you want to think about, again, not exclusive to e-visits, is making sure that you have a plan to take care of the tasks that come out of the visit afterwards. And so some of those things might be making sure that recs get submitted, or requests for blood work or prescription changes, follow-up appointments, all those sorts of different things that you do on a day-to-day basis. You have mechanisms for dealing with that in your in-person clinics, but want to make sure you're thinking about how those things can be taken care of as well, so that nothing slips through the cracks. Technology, obviously, you want to make sure that you and your patient have the required technology to be able to do this, and then training as well, ensuring that you have reviewed the appropriate material as applicable, and also, especially if it's your first time, recommend doing a test call in advance. So those are some of the things you want to think about in terms of setting this up. And if you want to advance the next slide, please, one. So the next thing, just a few quick thoughts on setting up and actually conducting an e-visit. Again, these are kind of get a little bit more into the weeds, but things that need to happen. The email address, you've likely need the patient's email address to set up an e-visit. Certainly in OTN you do. And so somebody has to connect with the patient to do that. Consent should be obtained, and we've recently at HHS changed our consent process to align with that which was recommended by the OMA legal counsel, and was approved by the CMPA as well, sorry, just to make it easier. And so just want to make sure people are aware of that, and so it's a verbal consent documented in the patient's chart and in your note, which is easier than what we were doing before. We've got some resources on that kind of stuff as well. If you're thinking about documentation, that should be done in the same way as an in-person visit. So yeah, we get questions on that fairly often, and it's just thinking about it in terms of the same way an in-person visit is done, with the exception of it being done over a different type of media. So definitely keep that up. And then a backup plan as well. I know sometimes, with technology, and we experience it, there are times where e-visits won't be successful. Sometimes it could be a patient's Wi-Fi or whatever the case is, but you should always have a backup plan in the event that it doesn't work. And most often, depending on your clinic flow, the easiest thing to do would be just to call the patient, particularly in the context of having the ability to do that with the telephone K code as well, and just trying to recover the visit that way is helpful. And then finally closing the loop as well. So again, making sure you followed the predetermined process to complete the tasks after the visit. The only other thing that I kind of just wanted to say as well in the context of this is, certainly video visits is one option, phone is another. Some people, are moving towards one or the other, a combination of both, and I think that's great. What I do want to highlight though is that, you obviously have to use your professional judgment ultimately, which is no news to you with respect to what is most appropriate. The reality is that doing an e-visit and setting it up is a little bit of extra work. And so, and there's the potential that it might not work based on technical difficulties, although by and large it does. But I think, for your sanity and for your patient as well, you just want to really determine whether or not seeing the patient is what you need to do. And if the answer is no, maybe a phone call is the better option. But just wanted to leave that with you, and happy to answer questions. Certainly I'm available for people practicing at Hamilton Health Sciences to support in terms of setting this up and helping you navigate some of these processes and conversations. So thanks very much.
So perhaps that we can start with answering some of the questions that have come through. And so there was a very good question regarding the billing codes, the K codes, presumably, and whether physician assistants can use these codes. I have to say, personally, I'm not certain of this, and certainly I'm not sure if Juan or Nate have any comments to that effect. But from the perspective of billing for a physician assistant in that situation, I quite honestly cannot say. I think the K codes really are a new development, and there may be some nuances that require some clarification, but I'm happy to hear otherwise from either Nate, Juan, or anyone in the crowd about that.
So I think it's applies to the new regulations in terms of extenders, right? So if they are under your supervision, certainly you can apply the codes. If they are doing it independently, right? So without your supervision, then like a nurse practitioner, then you are gonna need to you won't be able to bill it, right? So, and the other thing is, remember that you are, as a specialist, we are not billing only the K code. We are billing our follow-up or a complex assessment or reassessment, depending on what we are doing with the patient.
Great. No, that absolutely makes sense. The other question, or another question, was booking codes for e-visits, and there are actually a number of questions around what are the booking codes, or are there booking codes in Meditech for e-visits, and should every patient or all patients being seen within Hamilton Health Sciences be registered in Meditech? And the answer to both of those questions is yes. There are specific codes that designate a patient as an e-visit, and all patients that are being seen in the HHS environment should certainly be registered. So thank you for those questions. There's also a question about the advantage of an e-visit versus telephone, and this is certainly a question that bears some consideration. There are, of course, both advantages and disadvantages, some of which Nate had actually alluded to in his presentation. Um, of course, e-visits do require a little bit of work to set up, but generally speaking, there are some conceivable advantages to an e-visit versus a telephone visit. An e-visit does allow visual assessment of certain things. So there are nuances of a patient's presentation, physical appearance, potentially, stigmata of one variety or another that have diagnostic utility. And so depending on what type of practice you have, there may be added information that is gathered visually in assessing a patient rather than just on a telephone visit. The other part of it, of course, is, and certainly there are evolving literature in the value or the psychological benefit of face-to-face interactions with a provider and a patient in comparison to telephone conversations alone. And certainly, the evidence in this area is not conclusive, but there is some sense that that the sense of well-being and psychological benefit to a virtual visit with a visual component may be helpful, and particularly in consideration of the current situation, that may be even an added value in context. So it's important to keep those things in mind. Again, as Nate mentioned, the ability to change from one mechanism to another is one of the values of versatility in this virtual or remote ecosystem of evaluation. And so, not uncommonly, I've had situations where I've had an e-visit with someone, and for technical reasons or other reasons, they've not been able to complete their e-visit, and we've actually, communicated or completed the assessment via telephone. And of course, the versatility in this environment is going to be even more important given the evolution of the need for a variety of mechanisms of assessment. So, I don't know if Juan has any other comment to that question.
I think the overall issue is that you need to adapt it to your own clinic and your own specialty. I mean, in my case, I use it for follow-ups and it works very well. So you also need to develop a structure of your clinic. So what I do is when I have e-visits, I do it in one particular set of time. So either in the mornings or in the afternoons of my clinic. In that way, there is no conflict between the in-person visits, because as you know, especially in, for instance, in our cardiology clinic at the General, sometimes we have traffic jams in registering, and the patients take forever to register. The patient come late, so the flow is quite slow. So that's why it's important that you guys set the e-visit in your own, in your own time, protected time. In that way, you're not going to have any disruptions. Anything else, Nate?
No, I think that's yeah, that's good on that question.
You know, again, the utility is going to depend on your practice type, and certainly I see some commentary from Dr. Lima about you know, assessment of dermatological lesions and whether or not there could be some accuracy in this context. Again, you have to use your clinical judgment. It's not necessarily just lesions that you're looking for that may be added value in visual evaluation. It may be a sort of a clinical gestalt of assessing the patient for other signs and symptoms. But you have to use your judgment and common sense. And it's very difficult to be prescriptive in every specific clinical context. And so really you'll have to evaluate your own practice, the type of information you require from the patient in any interaction, and acknowledging that in the current context, physical assessment is going to be restricted to some degree, and what information can you gather by various mechanisms that allows you to best provide the care for your patient. There's also a question about why MDs can't register their patients to attend them to speed up delivery of care. So it really depends on what registration you're speaking of. MDs can certainly populate and send invitations through the NCompass scheduler in OTN. But if you're talking about registering them in Meditech, most physicians that I'm aware of don't have the administrative privileges to do that. So fundamentally, you know, ad hoc, I've many a time sent an invitation or a change of an appointment to a patient through Encompass to be able to arrange a prompt e-visit. And there's no restriction in doing that. But as far as administrative privileges in Meditech, it's certainly not easily done without the appropriate credentials.
Yeah, and just to be clear on that point, I think a lot of times what we try to do is register the visit or attend the visit in advance so that you have the ability to do your documentation and finalize that at the time of the visit. There just has to be some sort of a feedback mechanism, fortunately or unfortunately at this time, to let us know if the visit hasn't happened so that we can change the status of the appointment. So it's a technical thing, but it allows you to do your documentation in real time.
Absolutely. So there's another question about documenting start and stop times. No, that's not necessary with the eVisit platform. That's actually documented internally by the system when your visit started and stopped, and so that's really not a requirement of you independently of the system itself. There was also a great question by Azim about the need for special consent for learners, such as residents or medical students. No, although a lot of this is generally evolving, and certainly I have an interest in the potential application of e-visits in CBD education ecosystems. So, you know, residents and medical students perhaps not, but residents, I believe, can register for a profile in the OTN system and conduct e-visits as would normally be applied. Although Nate, perhaps you can give some clarity to that.
Yeah, so we've actually been getting a lot of requests around residents getting access, and so we are working with OTN on understanding that better, because historically they couldn't, and I've heard as early as today that they will be actually opening up and waiving fees to allowing residents to sign on as well. It's just a matter of how do we work through that mechanism now, and get them onboarded as well. The other thing is with respect to consent, you know, given that the consent considers that it's a private conversation, I think it wouldn't hurt just to confirm that if there's other people in the room with you when you're doing the e-visit with the patient, and get their consent on that part as well.
And to that point, there is a standard etiquette that you should become familiar with, and certainly we do have documentation, and OTN provides documentation about sort of etiquette steps to consider in setting the appropriate stage and environment for conducting an e-visit most efficiently and with respect of confidential information and information exchange. So. So again, these are elements that are incorporated in the standard exchange. There was also a great question about finding whether we found that elderly can cope with the instructions for e-visits. Believe me, it is rarely an age-specific phenomenon as to whether someone is successful or unsuccessful in an e-visit. I've been surprised both ways, and so I make no preconceived judgments generally, or at least try not to. I generally offer at least the opportunity for all of my patients that I feel are suitable for this mechanism in general, based on their initial evaluation, and whether they feel comfortable in engaging in that. I certainly give them an opportunity. Sometimes we have technical challenges related to, as Nate mentioned, connectivity issues and the network, their own personal networks. But by and large, I do not find a consistent theme that successive and e-visit is age specific. And so, despite the sort of conceptual challenges that may have, that doesn't really seem to be something that I find personally. I don't know if Juan's experience emulates that.
Yeah, I agree. So what we have seen in my clinic is that, regardless the age, the patients are comfortable doing it. I think it's simple from the patient point of view. It's simple because the patient gets an email with a link, like the same thing like a Zoom, right? So it's actually pretty simple from the patient perspective. So I think that's make things easy. And all the elderly patients already have iPads and computers, and actually the issue is the camera, right? So if they have a device with camera, and my assistant, what it does is when she's booking the appointments, she asks them what type of device they have, and give it a little bit of tutorial of how to do it.
Thank you, Juan. So there's another question about patients being able to email pictures within e-visits, and if they can't aim the camera at their specific body part. So email is completely separate from the personal video conferencing software. The etiquette around email obviously is an entirely different point of conversation, particularly related to privacy and security concerns. Generally speaking, I don't necessarily have that integrated into my practice for a variety of reasons, but certainly you can use a judgment in your particular practice environment as to whether or not that provides value that would be helpful. But no, as far as the actual software itself and the e-visit etiquette, there really isn't that sort of interconnectivity between those things. There was also a question about having a phone call prior to the video call. So the OTN software sends out an automated reminder prior to the patient's scheduled e-visit, and it's done via email. A point of practice, actually, I usually tell patients to make sure that they check their spam box. On occasion, some of the OTN emails, depending on your spam settings, can actually go into the spam box, and so it's important to make sure that patients understand that that email may end up there. But they are sent an automated reminder of their visit in time prior to their actual encounter. You can actually also manually send another reminder yourself from inside the OTN scheduler. So I actually find that functionality quite helpful as well.
There's a question out there as well about how many people you can have on a call, and so you actually can add additional people into the call as well, which is helpful. And to Ted's point, everybody who's added in gets that email with the link, and so they can join as well. I know people are asking about patients in different places, or including family members, or even residents for that matter, or other clinicians if there are multiple in a clinic.
There's another question about vital signs, for instance. So particularly in my clinic, I ask my patients to have a blood pressure monitor. they know from the visits what is my approach to blood pressure. So and I asked them to provide me with those numbers. Again, this is the comfort of individual practices, and certainly depending on the patient. But it's something that you can incorporate now. There are different tools that the OTN is promoting in terms of heart failure follow-ups and COPD that are actually hardware that is integrated to OTN, and you can use in order to obtain biometric data such as weights, pressures, and heart rate. So, but that is more for the heart function clinic or the COPD clinics.
There's also a question that I think is actually a very relevant question about ordering blood work, and we can even extend that to other types of investigations, imaging, order endoscopic investigations, echocardiography, et cetera, et cetera. And the etiquette around how that actually is conducted in an e-visit. And this is actually one of the elements of personalization around a telemedicine encounter that I think warrants mentioning. Everybody has their own approach. I, for example, fax requisitions to the patient's preferred lab following the encounter, or at least my administrative assistant does. As far as scheduling endoscopic procedures or other investigations, that's usually done after the fact, but I'm actually completing the requisitions in real time, either through our Oscar EMR, which is the EMR that we use in the GI group, or paper-based requisitions, depending on the circumstances. And so really how your standard workflow, as it would be when you see a patient physically in a real-time encounter, and how that's actually reproduced in a virtual context is something that you'll have to think about and try to work out in an efficient fashion. And it did take a little bit of time for me to work out that flow, particularly when you have appointments that are 15 minutes and you don't have a lot of time to actually go through extensive bookings or that sort of thing between patients, depending on how much time the encounter itself takes. So you're going to have to think about how that process might operationalize for you. And the advice I would give, as had been mentioned by Nate in his part of the presentation, take the time initially to do some testing. And so you might want to book a few patients for sort of longer visits, maybe even half-hour encounter or even 45 minutes, depending on what type of clinical assessment you have. And provide that as an opportunity, a test session, to kind of see how the encounter materializes, how you'd actually order some of these investigations and the processing around these investigations integrated into your particular practice environment. So it's very difficult for me or anyone here, of course, to be prescriptive about how that materializes in your particular practice. But what I would certainly suggest is actually allowing yourself an opportunity to test that specifically. And so certainly I think that's the approach that both Juan and myself have taken in our sort of comfort in developing specific workflows around an e-visit or even telephone encounters for that matter, as are sort of relevant in the current context. The other thing I would actually say around that is it's always great to be prepared for an encounter somewhat. So I don't mean you have to prepare extensively for every single patient encounter, but be familiar with the patient. And particularly if you have, stacked encounters where you have 15-minute encounters between patients, you may not have a lot of time to prepare for the subsequent evaluation, both either as an e-visit or a telephone visit. So it pays to be a bit prepared. And what I mean by that is, I actually have a standard e-visit encounter form that I pre-populate with some just pertinent information that I'm wanting to review with a patient. So, for example, follow up on some previous prescriptive approach to their symptom management, or maybe some investigations that were recently completed, to allow me to very quickly evaluate that patient and move through the encounter efficiently and with some purpose. And so that is the one thing that I learned very early on, is that you really need to have some degree of preparation in order to be able to move through a sizable volume of patients efficiently and without much in the way of interruption. And I don't know if that's been your experience as well, Juan.
Yeah, I agree. I mean, what I do is I give some extra time between consults or between visits to review quickly a patient or do the administrative stuff, signing requisitions or referrals and things like that, to give you some time in between. Because if you book the patient, in my experience, back to back, sometimes you're gonna end up having delays and it's gonna affect the pace of the clinic. I give 10 minutes, window to uh, to maintain the pace during the e-consult.
Absolutely. And you do find that there are natural efficiencies in the lack of turnaround time between patients in a physical context that actually make up for the perhaps having a bit of a buffer between different patients. And so from an efficiency perspective, it's actually I actually find that it, in some situations, actually be quite a bit more efficient to do patient assessments of a particular type in this situation or this type of context. But that will depend on your practice, of course, and it's difficult to say what that will look like for every single person. But in any case, these are things to consider. I think in the interest of time, I'll try to move on to a few other questions, and some of them have been addressed in a variety of different contexts already. We've talked about the ability for multiple users to simultaneously join an e-visit, and they can do this, again, from separate computers without having to be in the same room. Of course, from a CBD context, it might be valuable to have the patient in the specific room and evaluating them in real time, and provides a really neat opportunity to do that, and something that I would bear into consideration for those of us involved in CBT and education. Let me just go through some of these questions because they're coming fast and fierce.
Oh yeah.
Let's see. A lot of these are billing questions and related to a variety of different application of a variety of codes, and again, that will be dependent on what type of encounter you have. K codes definitely can be billed with e-visit encounters, provided that that was actually the purpose of the appointment and in a counseling context.